All right, here we go. So let's get into the stuff that y'all probably been waiting all semester to kind of do. I've learned all these strips. I've learned how to look at them. But what does that really mean if I see this strip or this thing on the ambulance? What am I going to do? And that's what we're going to talk about today. This little sheet that I handed out is going to be your best study tool. All right. I've kind of went in and dissected and cut and made my own stuff as far as this goes from what the book. So I'm going to vary away from the book some as far as the order that it goes in, but we're staying all American Heart Association 2010 stuff. All right. If you take good notes and you know your American Heart Association algorithms, and you're able to interpret the strips, that's what you need, and that's what's going to help you, okay? Now, of course, there's a couple processes that we're going to talk about a little more. Defibrillation, synchronized cardioversion, pacing, things like that. But I'm also going in and I'm going to review your cardiac medications very good for you so that you understand, or I hope you understand, the whole purpose of those cardiac medications as it applies to our class. Every cardiac medication that we're going to talk about is on your algorithms. These are going to be your best study tool. All right? So, we get done with this class, I'm going to have you at some point take the ACLS pre-test, and then at the end of the year, you're going to take the ACLS post-test, and this is going to count as your ACLS class, so you'll get your cards when you graduate. All right, instead of having to go through the whole ACLS stuff. So everything that I'm going to talk about is going to stay in line with American Heart Association stuff. What is the main purpose for cardiac management? It seems like a dumb question, but what is the main purpose of us managing cardiac?
To save lives.
All right, to save lives, but what is our goal as far as managing what's going on with the heart? What are we trying to do? All right, we're trying to prevent further damage, but now let's talk about more of dysrhythmias. What mechanical aspect of the heart is a dysrhythmia going to affect? Cardiac output, right? Perfusion, pulmonary perfusion. So our main purpose for cardiac management is going to be to restore cardiac output. It's going to be to restore a normal the normal electrical pathways of the heart, to restore heart perfusion, and to try to get the heart back to a normal homeostatic balance. Consider this. If you look on your strips, if you look on your algorithms, it doesn't get real in depth. It just says, if this is happening, do this. If this isn't happening, check this, then do this. There's 3 basic types of management for cardiology, all right, for cardiac management. That's going to be your non-invasive therapy, vagal maneuvers, things like that, monitoring, things like that. You're going to have your pharmacological therapy, and you're going to have your electrical therapy, all right? Couple of questions that you need to consider. Is it too fast? Is it too slow? Is it not moving at all? If it's too slow, we're going to manage it. If it's too fast, we're going to manage it. If it's not moving at all, we're going to manage it. It doesn't matter across the board if it's Mobitz type 1, 3rd degree heart block, AFib RVR. We're going to really just break it down as simple as we can. We're going to identify and we're going to determine, is it too slow? Is it too fast? Is it moving at all? All right? And so when we think about that, we not only think about the electrical aspect, but we're also thinking, is the heart muscle pumping too slow? Is the heart muscle pumping too fast? Is the heart muscle moving at all? If all those are normal, then what other factors are affecting cardiac output? You remember your formula for cardiac output? Stroke volume times heart rate equals cardiac output. Every one of your strips, every one of your dysrhythmias is going to affect some aspect of this formula. Alright? Your bradycardias are going to affect your heart rate. Your tachycardias are going to affect your heart rate. They're also going to affect your stroke volume. Your bottom line is that what do we need to do to restore cardiac output? Does that make sense? Use this as the basis of all things to do with cardiac emergencies. What do I need to do to restore cardiac output? Bottom line, no matter what cardiac medication you give, no matter what type of electrical therapy you use, no matter if you're doing CPR, no matter what the treatment is, your main goal is to do what? Restore cardiac output, restore cellular perfusion, right? To get the old ticker ticking back. So, bottom line, we're going to figure out which of the factors it is that's affecting cardiac output and what we need to do to fix it. So this is just kind of a universal algorithm here. We'll get to this again. But you just look at your chest discomfort, look at your time. Is it shorter than 12 hours, longer than 15 minutes, and shorter than 12 hours? Yes. Interpret the ECG, STEMI, all that stuff. Y'all can go back and read all this. But basically, it's everything we just talked about in the 12-lead stuff. We need to get them to the hospital. But that's not really what our focus is right now. Do y'all want me to leave the lights off? Brandon Elliott does not want me to leave the lights off. What? So that's kind of the introduction, and we're going to get back to the cardiac output, but we need to look at exactly what we need to do as far as electrical management goes. All right? So we're going to look at electrical management, we're going to look at pharmacological management, and we're going to look at non-invasive management. All right? Defibrillation. Is it jump-starting the heart? No. No. It's what? So it's basically making every cardiac cell do what at one time? Depolarize, right? The idea behind it is that when the cells repolarize after the shot, they respond to an impulse from the SA node. The SA node being the what? Primary pacemaker, right? Defibrillation is of paramount for VFib and pulseless VTAC, right? Y'all know that. It's not useful in asystole. Why is it not useful in asystole?
Because the cells aren't moving. Not going to do the shot.
Yeah. I've heard medics dispute that before, but for all intents and purposes, the whole point in defibrillation is to take those cells that are firing by the principle of automaticity on their own, just at will, and just kind of giving them one sudden jolt and making them all depolarize at one time and hopefully getting back into our normal pathways. The reason why early defibrillation is important is because your most frequent initial rhythm in sudden cardiac arrest is VFib. One of our shockable rhythms, right? We can do CPR all day long, but without shocking them, we're not doing the most appropriate treatment, right? The probability of successful defibrillation decreases rapidly over time. Remember your chain of survival, all right? Early access, early CPR, early defibrillation. And if we don't get it on them fast enough, then VFib goes to asystole. All right? It doesn't have anywhere else to go but to asystole. We can do a lot more with VFib than we can asystole. Right? Manual defibrillation. I've already taught y'all how to swap from AED mode to manual mode in the Zoll monitor. Y'all know about the AEDs. Important, and again, I know that y'all know this, but let's just refresh. Make sure no one's touching the patient. Whenever we do our stuff, I just want you to get into the habit. When you get ready to shot, I'm clear, you're clear, we're all clear. So there's no hesitation, there's no doubt whenever you check off the registry that you have cleared your patient. Alright? Pooled water, duh, we don't want to shock somebody in, one of the best conductors of electricity, right? Don't defibrillate patients who's touching metal. You can shock somebody that has an implanted pacemaker or AICD, but don't put it over it. Y'all all seen patients with these pacemakers, right? Where you can see the battery pack right up under the skin. Be sure you dry your chest, attach your pads. Your energy level is going to be at 200 for biphasic machines. Most of the machines that you're using now are biphasic. Alright, I've explained that before. Do y'all understand the process of biphasic? You've got one shot going down, one shot coming back up, whereas a monophasic just shoots one larger shot down. Alright? Y'all know how to manually defibrillate. These are your placements. Now, it's being more and more accepted to do an anterior-posterior placement. Alright? We do that a lot in the hospital now, but you know, generally it's going to be your mid-clavicular, left mid-axillary. Duh, we got that. Alright? Very important to remember, when we shock, we immediately do what? Resume CPR, because even if we get something back, our heart's probably not going to be strong enough to perfuse. It's going to need a little extra help. When do we check pulse? 2 minutes. Alright, be sure your defibrillator is working. Patients who do not regain a pulse on the scene usually do not survive. Transport the patient. When the patient regains a pulse, 6 to 9 shocks have been delivered. The defibrillator gives 3 consecutive messages that no shock is advised. I don't know where they got these guidelines, but transport the patient immediately if you think that if it's not been a very long downtime. Okay. Now, we talk about regaining a pulse and surviving. Does that count as a save if we just get a pulse back and they survive? Yeah. A save is not going to be somebody that got a pulse back, went up to the ICU, and the family had to make the decision to take them off life support. Alright? A save is going to be, we got them back, their heart started perfusing, they went to the cath lab, they had their interventions done, went to the ICU, might have been on a Dr. Cool protocol, but they walked out of the hospital neurologically intact. Alright? AED, I'm definitely not really going over the AED stuff with you again. Cardiac arrest during transport. Alright. Says that you should stop the vehicle, shock, analyze, all that stuff. If the patient loses consciousness, check for a pulse, stop the vehicle. That's what I just said, isn't it? I forgot to delete the other one. These are a little bit better instructions for CPR. I found these the other day. I like the Capri Sun straw.
I like number 6. Picture your life together.
Once dead, feel free to enjoy any remaining Capri Sun. It's pretty funny, pretty funny. Just thought I'd bring a little cheer in your life. Alright, biphasic technology. We just kind of talked about this. In the past, defibrillation has used monophasic waveforms, which only travels in one direction, from the positive to negative. The problem with these is that it required sometimes a lot more electricity to be shot through, but the heart may not have needed that much. They also require large batteries, and they're just very hard to maintain. So most of your new things are biphasic. It goes and comes back, all right? So therefore, you're getting a double dose of electricity, and you're not having to send so much electricity through the heart, all right? Synchronized cardioversion. I remember in lab, the first of the semester, I kind of showed you the ins and outs on the monitor. We're going to refresh on that because I know it's been a while since y'all seen it. But the thing about it is that synchronized cardioversion is when we use the defibrillator to determine hemodynamically unstable tachydysrhythmias, to terminate, all right? So what is the difference in unsynchronized cardioversion and synchronized cardioversion?
Synchronized, it matches up with the rhythm that's already there.
Okay, so synchronized cardioversion is going to it's going to find the R wave. It may not shock as soon as you hit shock. It's going to actually sync up with the R wave, and it's going to defibrillate on ventricular depolarization, all right? Unsynchronized cardioversion is just the fancy word for defibrillation, all right? It has no discretion of when it shoots the cardiac electrical activity. The electrical shock through the heart, it just shocks the heart, all right? So with your cardioversion, energy delivery at the peak of the R wave increases the probability of depolarizing the myocytes. What the idea is that we're going to hit this unstable, hemodynamically unstable tachydysrhythmia. What are some of those? SVT, VTAC with a pulse. Not VFib, because it's going to have its own protocol. AFib, RVR. All right? Shall I talk about AFib, RVR? AFib with a rapid ventricular rate, rapid ventricular response. It's performed just like you would do defibrillation, except you select the synchronized settings and you sync it up first. Again, this is only done with severely impaired cardiac output. All right? We're going to get to that in just a little while to make that determination. When done on a conscious patient, he or she must be sedated. What do you think we're going to use for sedation? Valium. May throw a little morphine in there. All right. Transcutaneous cardiac pacing, TCP. Transcutaneous across the skin is the pacing we're going to do. Again, we're going to make the determination, are they hemodynamically unstable? Are they refractory or not responding, to atropine? It passes through the skin across the heart. The pacer is set for a specific rate, and energy is increased until the heart responds. That's where we slowly, if y'all can think way back when we went over this, we slowly increase the milliamps until we get capture, right? Because the idea is and it's the whole idea of going to the biphasic technology and all that. We want to give enough to make it therapeutic. We want to give enough electricity to make it therapeutic, but we don't want to overkill, right? We don't want to give too much. Now, what happens if you've got a pacer that's set to 60 and then the heart decides it wants to start beating at 70? Yes, stops pacing and lets the SA take over. The pacer is there just to catch it if it starts going below 60. Okay? And so we're going to look at capture, make sure that we got capture. Most commonly, the most emergent is going to be our Brady dysrhythmias or blots associated with severely reduced cardiac output. I just showed this picture because this is just showing where the pacer spikes would go. All right? So a pacer spike's going to go on the P if it's a atrial pace, and it's going to go just before the QRS complex if it's a ventricular pace. Okay? All right. Getting on into too slow. Y'all with me so far? It's definitely not as bad as it has been. What do you think is going to be the aspect of cardiac output in our Brady arrhythmias? How are Brady arrhythmias affecting cardiac output? What?
They're just slow. Your heart
Yeah, your heart's not, it's not moving fast enough to keep up, right? So that's going to affect your preload, it's going to affect your afterload, it's going to affect your contractile force. One thing to remember though about cardiac output, I mean not cardiac output, but Brady, especially if it's just like a sinus bradycardia, some people live with sinus bradycardia. Very athletic folks have really slow heart rates. So, actually, my heart has a beat double to keep up with me. So, the bottom line across the board when we make our decisions for any of these treatments, well, mainly bradycardias and tachycardias, is going to be symptomatic or not symptomatic. All right. So, bradycardic, they're symptomatic. First step. Look at your algorithms there. First step, IV, right? We got to have an IV. We're doing our ABCs, moving to an IV. Then we're going to give what? Atropine. We don't want to give fluid initially. If our heart's not beating fast enough, that's just going to increase preload. We're going to give atropine. Atropine is going to be your number one first line medication for bradycardias. If no response to atropine, then we're going to begin transcutaneous pacing. If all this is unsuccessful, we're going to consider a sympathomimetic drug. What are some of your sympathomimetic drugs? Epi, what else? Dopamine. All right? So your algorithm says dopamine or an epi drip, right? So our medications, our first line is atropine. Our second line is dopamine. Our third line is epinephrine. So atropine, what is it doing? Okay? So it's acting on the SA node? All right? So our idea behind giving atropine is that we want to what? Speed up the heart rate, right? Dopamine. Dopamine has a couple of properties. The main properties that we are using, the properties of dopamine that we want for bradycardias is going to be the chronotropic properties. The chronotropic properties, right? Remember inotropic, dromotropic, and chronotropic? So dopamine, it's got inotropic properties, all right? Inotropic properties affect what? Yeah, the contractile force. And chronotropic are going to affect what? The rate. Okay? So yes, it's good that we're affecting the contractile force, making the heart work a little bit stronger. But we really want to give the dopamine to get the heart rate up. And it will get the heart rate up. All right? But the problem with dopamine, epinephrine, these kind of medications is that they're also going to be vasoactive as well. All right? So we give too much, we're shooting heart rate up, we're shooting blood pressure up. We're increasing contractile force on the heart. All three of those together, what is that going to do to the heart? Yeah, it's going to tax it. It's going to wear it out, right? It's going to increase myocardial oxygen demand, right? Then our electrical therapy, what we're going to do is trans-Q pacing. And then they can go to the hospital, and in the cath lab, they'll actually do transvenous pacing, where they go in that same area in the groin, and they run pacer wires up and attach them to the heart. And then we have I don't work there anymore, but we have an electrical box that we control the milliamps, the rate, and all that. Alright, so they pretty much have wires running up into their body with a box hanging out, and we have to be real careful with those. But what do you think that they're going to be a candidate for if they're having to get a transvenous pacer? Yeah, an implanted pacemaker. Yeah, you guys are so right. So your major bradycardic ECG rhythm: sinus brady, first degree AV block, your second degree type 1 and type 2, and your third degree. Alright? What's important to remember is your type 2 and your third degree, pretty much on most of your blocks, you're usually not going to see any symptoms with first degree AV block unless it's first degree AV block sinus bradycardia, and then you're just really worried about just their overall perfusion, period. But with your blocks, atropine really ain't going to amount to ill being for these. We're going to have to kind of go straight to pacing. All right? So let's look a little bit more at your medications. I know that y'all have medications. I know y'all are in pharmacology right now. But I want to be confident that you know your cardiac medications, all right? Now, I don't care about the 500, beta blockers, calcium channel blockers. I care about the ones that are on your American Heart Association stuff, the ones that I'm teaching you in this class. You've got to know these for your algorithms, okay? You've got to know these. When you do static cardiology and dynamic cardiology, you're going to use your algorithms, all right? So your atropine is an anticholinergic. Cholinergic, what nervous system is that? The parasympathetic, so it acts against the parasympathetic nervous system. So sympathetic speeds everything up, parasympathetic slows it down. You get a parasympathetic response that equals bradycardia. What is the most common parasympathetic response?
Vagal.
Yeah, vagal response. Don't need to do that too bad. Too much. So, its main properties, it blocks the parasympathetic response. It is an anticholinergic, right? It acts against the parasympathetic nervous system. Slowed heart rate equals poor cardiac output. So, our dose for bradycardia is 0.5 for a total dose of 3 milligrams. Alright? Our max dose is 3 milligrams, is 0.5 milligrams. Alright? A pre-filled atropine, what does it come in? 1 milligram. So we're just going to give half of that, right? Dopamine. It's a sympathomimetic. Mimics the effects of the sympathetic nervous system. The sympathetic nervous system speeds everything up. What are the receptors in the sympathetic nervous system? Starts with an A, ends with ergic.
I know it.
Adrenergic. Your adrenergic. Alright? Those are your what? Your alpha and beta. Your alpha and beta. Alright? Alpha 1, alpha 2, beta 1, beta 2. Remember those? Got my eye on you. Mm-hmm. So your dose is going to be 2 to 10 mics per kilogram per minute. Y'all know how to do these weight-based formulas now, right? Y'all been pretty much tested into the ground with this stuff, right? Not a big deal. Your dose times your weight times 60 drips divided by 1,600. So most of your what? Well, that's what I was about to tell you. Most of your pre-hospital concentrations are going to be a 1,600 mic concentration. It's 800 milligrams per 500, which equals 1,600 mics. All right. Or it might be the 400 per 250. Yeah. This is in your Alabama protocols. Alright? We don't have time to do this formula on the back of the truck, right?
No.
5, 10, 20 mics, if they weigh 120 kilograms, we're going to start at 23 milliliters per hour. Alright? Does that make sense? Very easy, very easy. You may need to use a dial-a-flow. Do y'all know what a dial-a-flow is? Dial-a-flow where you just set how many milliliters per hour you want. Right? Your epinephrine infusion, same properties as dopamine. Your dose is 2 to 10. What was your epi dose? Your dopamine dose? 2 to 10. Your epi dose? 2 to 10. Alright, here's your algorithm. ABCs, cardiac monitor. Is it a bradyarrhythmia? If it is it causing hypotension, acute altered mental status, signs of shock, ischemic chest discomfort, acute heart failure? All hemodynamic signs. If not, why would we need to pace them, or why would we need to give them medication? If they're asymptomatic, let's just figure out what's causing their symptoms. I guess they wouldn't have symptoms if they were asymptomatic, huh? Alright? If it's yes to anything in the pink, atropine, what was your dosage of atropine? 0.5 for a max dose of what?
3 milligrams.
Alright? If atropine's ineffective, trans-Q pacing or dopamine or epinephrine. Alright? A lot of times the doctors are going to want you to try dopamine next before you start trans-Q pacing. Okay?
So the pink box, is it all or none?
No. It can be just one.
Okay.
It's just any sign of hemodynamic instability.
Would you, like you did actually, would you get RMD to start, progression to start dopamine?
Yeah.
You would?
Yeah. I'd go ahead.
You like already gave that thing what it is.
Yeah. I would go ahead and call them and just say, hey, you want to start some dopamine or something.
It's category B, isn't it?
I think so.
Got it.
Okay. So, remember you've got your farm treatment, your electrical treatment, and your non-invasive. What was our pharmacological treatment of bradycardia?
Dopamine.
Atropine, how much?
0.5.
All right. What else?
Dopamine. 2 to 10.
And what else? And it's the same, right? What's our electrical therapy?
TCP.
And then non-invasive is just going to be monitor, right? So really not doing much treatment there. All right? I want you to take every one of your strips and just break it down to what's my farm treatment, what's my electrical treatment. If I'm not going to do either one of these, am I going to do anything that's non-invasive? Okay? Make sense? Y'all need a break? Yeah, I do. Recording in 3, 2, 1. Alright. So we've looked at our 2 slow, which was just your Brady's, right? So now we're going to look at 2 fast, tackies. Remember there's 3 aspects we're looking at. 2 slow, 2 fast, you're not moving. Your tackies. Why is cardiac output affected?
Doesn't give enough time to set it up there.
So it's going to affect your heart rate by being too fast, and by being too fast, it's going to affect your stroke volume, right? Because it's not allowing time for ventricular filling, all right? Not to mention that if it's just a ventricular tachy, then we're not getting a lot of flow from the atria into the ventricles. You need to decide the seriousness of the symptoms. And your tachycardia is going to be very, very important to look at your symptoms, look at your symptom management. Chest pain, dyspnea, hypotension, and altered mental status. Rates of 150 beats a minute rarely cause serious signs of tachycardia. All right. The slowing heart rate of a patient compensating for a medical condition may be fatal. So if a patient is, in some type of shock or something like that, and they've got a tachyrhythm, and their heart rate starts slowing down, their heart rate was tachy for a reason, right? To compensate. So they may be starting to decompensate. Unstable symptoms result from tachycardia, or if unstable signs and symptoms result from tachycardia, cardioversion is needed. If they're mild, slower, but safer treatment is recommended. Determine the origin of the pacemaker site of the rhythm. What does that mean? If we're looking at a tachycardia, what does that mean? Determine the origin of the pacemaker site. Is it a junctional tachycardia? Is it an atrial fib with rapid ventricular rate? Is it an SVT? Or is it just a ventricular tachycardia? All right. Where is the pace coming from? So the ones that fall under that is going to be your atrial fibrillation, all right. Now we're looking at more of fast rate AFib RVR, all right, and on those it may be hard to determine if it is an irregular rhythm, all right. I should have put it up in an AFib RVR. Atrial flutter. Remember your flutter waves? All right, so you may have a very fast atrial rate. So we're looking at our site of pacemaker. Okay, right. Your SVT. Now, where does your SVT, what rate do we start treating SVT? Or what makes it SVT as opposed to sinus tachycardia? So you can't see the P wave once it gets to about 180. We're definitely looking at some unstable signs and symptoms. Your monomorphic VTAC. Alright. And then your polymorphic VTAC. Now, your polymorphic VTAC and your monomorphic VTAC, if you've got a pulse with a VTAC, we're going to manage it under this algorithm. If it's VTAC without a pulse, we're going to manage it under the pulseless arrest algorithm. Alright? And then any wide complex tachycardia of uncertain types, it's just fast. We don't really know where it's coming from. So, one of the important questions that you need to ask yourself while treating this patient, are the symptoms coming from this tachycardia? Because again, usually a heart rate, a sinus tachy of 120, 130 as a result of, Red Bull or, some kind of stimulant isn't going to cause a whole lot of symptomatic stuff that would be related to this, okay? When I drink a lot of caffeine, I can feel it kind of fluttering and I can feel kind of drained, but it's really not enough to where it's going to be some type of symptomatic treatment. Does that make sense? We're looking at, are they hemodynamically unstable because of SVT or because of AFib-RVR? If the symptoms are from another origin, you must manage the underlying cause. And again, very important questions. Is a patient hemodynamically stable or is a patient hemodynamically unstable? And what is going to give us some clues into their stability hemodynamically? All right, mental status is going to be a good one. Appearance, blood pressure, pulse. All right? That's what we're looking at when we say hemodynamically stable, unstable. We're looking at that concrete evidence. All right? Vital signs, O2 saturation. We're looking at signs of poor perfusion. If it is a stable tachycardia, we can do vagal maneuvers. All right? So vagal maneuvers, where would that fall under?
Non-invasive.
All right? Then you can also try other pharmacological interventions. All right? If vagal maneuvers don't work and they still are stable, we're going to try a couple other medications. We'll get to those in a minute. If they're hemodynamically unstable, if they're going to die in the next 3 to 5 minutes as a result of this tachyarrhythmia, we bypass all the petty stuff and we move straight to what? Electricity. We start, we get orders and we go ahead and start synchronized cardioversion. Okay? So, a stable narrow QRS complex, and again, if you look at your algorithm, you're going to have treatment modalities for narrow complex and wide complex. Alright? Your narrow complex, what's going to fall under narrow complex tachycardias? A narrow QRS, SVT, AFib, RVR. And then also your sinus tachycardias as well. So, symptoms are being caused by the tachycardia, vagal maneuvers. If they don't work, then we're going to do adenosine. So there's your first pharmacological intervention. What's your dosage of adenosine? 6, not just IV, but rapid. That's very important, okay? All right. What's your second dose? And what's your third dose? Oh, it used to be 12. All right. If your adenosine doesn't work, now again, your adenosine's usually only going to work on SVTs. Okay? Just SVTs. I keep saying AFib RVR. AFib RVR is just a atrial fibrillation, but the heart is compensating and trying to keep up with the ventricle, so it is accelerated. Okay? They're going to usually respond more to some calcium channel blockers. All right? Beta blocker. American Heart recommends Sotalol. How do you spell that? S-O-T-A? What? A-L-O-L? Sotalol. All right. What's the dosage of Sotalol? I can't remember it right off the top of my head. All right. Yeah. It's 1 to what?
1 to 1.5 milligrams. That's just what's in this.
100 milligrams.
Yeah, that was fine. Alright? Alright. Neither here nor there at this point. It's a beta blocker. How's a beta blocker going to help with tachycardia? Its name tells you what it does. It blocks the beta receptors. The beta receptors are part of the what nervous system? The sympathetic nervous system. Sympathetic nervous system does what? Speeds everything up, right? Then some of your calcium channel blockers. We'll get to those in a minute. Alright? So this is narrow. Alright? If it's a wide, we may consider adenosine. But what's probably going to help with a wide complex, which is going to be like your VTAC with a pulse, is going to be your antiarrhythmic. And that's going to be amiodarone. Alright? And lidocaine if your ambulance still has it. Okay? This talks about carotid sinus massage. This is not a generally accepted maneuver for us to do in pre-hospital anymore. What are we going to do to get them to try to vagal down?
Bear down.
Try to get them to bear down against their epiglottis, right? To explain it to them in ways that they can understand. Act like you're taking a poop, but don't really poop. Never massage both carotid arteries simultaneously. Because you could cause significant bradycardia, you could also cause stroke. Alright? Consider the history, some of the things that may go into causes of tachycardia, thromboembolisms, some of the stuff you see there. We'll get into that a little bit later. So, your pharmacological management of tachycardias. It's going to be adenosine. Diltiazem, also known as what? Cardizem. Your beta blockers, Sotalol is the recommended one. Some of your other, what are some common beta blockers? Metoprolol, propranolol. Alright? Labetalol. Amiodarone. Amiodarone is what? Your antiarrhythmic. Alright? Digoxin. Digoxin is going to be a cardiac glycoside. It's also got antiarrhythmic properties. Alright? Verapamil. You remember what verapamil is? Calcium channel blocker. Then you got magnesium. When are we going to use magnesium? Torsades. Alright, so adenosine. When vagal maneuvers fail, and you've got stable narrow complex SVT. Again, stable versus unstable. Hemodynamically stable versus hemodynamically unstable. If they are stable, we've got time to play with medications and vagal maneuvers. If they are unstable, the heart can only maintain at 200 beats a minute for so long. So we need to go ahead and do some electrical therapy. It is a primary drug used in the treatment of stable narrow complex SVT. I reiterate, SVT, alright? It's just going to work in SVT. When given as a rapid IV bolus, it slows cardiac conduction, particularly affecting conduction through the AV node. Why is that going to affect SVT?
Because it's super ventricular. Above the
Right. So the AV node, that area, is probably where your SVT is starting to originate from. So if we're slowing conduction in the AV node, then it's going to trigger that SVT, right? It's going to target that SVT. It also interrupts re-entry pathways through the AV node and restores sinus rhythm in patients with SVT. What is a re-entry pathway? What?
That's a confusing question.
Well,
What's
what
that
did you
mean?
ask me?
What are you looking for?
What am I talking about here? A re-entry, an SVT causing re-entry pathway. Okay, so in this case, it's going to be we've got the originating pace in the supraventricular area. We're going to have re-entry of the electrical signal into the ventricles that don't just go through the AV node. All right, follows aberrant pathways. It goes into the ventricles in other ways than just the AV node. Does that make sense? And so it interrupts that re-entry, and so it kind of moves everything back to the AV node pathway. Your first dose of adenosine should be 6 over 1 to 3 seconds. Your best bet, I don't know if Brandy's taught you about it in pharmacology, but your best bet on the ambulance is to have your flush ready, hooked up to an upper port, and your adenosine hooked up to your lower port, because you want it at the fastest or the closest port, right? Go ahead and have your line pinched off. Push it quick, all right? Because if it don't, its half-life is very, very short. Like that. Very, very short. If the patient's rhythm does not convert out of SVT within 1 to 2 minutes, a second 12 milligram dose may be given. All efforts should be made to administer adenosine as quickly as possible. Now, what are we really looking for whenever we administer the adenosine? It may go through a cardiac standstill phase for momentarily, all right? A lot of folks call it the pucker factor stage, all right? It may go through that cardiac standstill, but then it should flutter back up and start going. Now, one way to determine is this an SVT or an AFib RVR, because if the AFib RVR is going so fast, you may not be able to determine if it's irregular or not. And so it may look a lot like an SVT. I had a patient in LaGrange that the first time I ever administered adenosine to, I just knew it was SVT. Called the doctor, got permission to give it, give the adenosine. He said, okay, give the adenosine. Look to see if you're going to have the cardiac standstill or if it flutters down. If it flutters down to about 90 and never actually goes flatline, and then flutters back up to that fast rate, that means that it is probably more of an AFib RVR. Then we're going to have to give another kind of medication. All right. So if you give that adenosine and it just goes down like this, in this case, the lady's heart rate, it was like 180, 190, 200, and it fluttered down to about 80 or 90, and then it picked back up and went back. All right. Adenosine's probably not going to work. You still should try your second dose, all right? But adenosine's probably not going to work because it slowed that AV conduction for just long enough, and then it got out of the system, but it didn't target the site where the ectopy is coming from. Does that make sense? Diltiazem, or cardizem. It is a calcium channel blocker. It slows conduction. So, thinking back, if you can remember it all, when we talked about the phases of cardiac depolarization, you got your phase 0, then 1, 2, 3, 4, right? It started at 0, right? Anyways, you've got your rapid influx of sodium where it spikes, right? Then you've got that little peak where calcium comes in. And what did calcium do? What did the influx of calcium do into the cardiac cell? It made it contract, it further depolarized it, but it really added that contractile force. Alright? So, if we give a calcium channel blocker, this medication is going to go onto that calcium channel, and it's going to block it. So it's going to keep calcium from going in. So what do you think is going to happen? It's going to slow the conduction down. It's going to slow the contractility down. Your heart isn't, your myocytes aren't having enough time, or at this point, they're not firing as fast because we've slowed the calcium down from going in. So if we slow the calcium down from going in, we're not going to have as quick of a contraction. All right? So that gives the heart time to recuperate and go through its refractory period before it starts another complex. All right? Does that make sense? Yes? Somewhat? All right? So that's why it's kind of important when we talk about doing the drug profiles and things like that, because if you can understand how it actually works in the heart, then you can understand a little bit better why beta blocker works like it does, or why calcium channel blocker works like it does. One of the most unimpressed clinicals I've ever had as a student, I was very impressed with this man's paramedic skills and his people skills. But I asked him to go through the drug box with me, and he knew those protocols backwards, forwards, and all that. And yeah, that's enough to get you by. But he did not have a clue how any of the medications work. He just knew you gave them. All right? I, for one, don't like to be like that. You know, I'm no expert, but I like to know if I'm given a chemical inside of the body, I would like to know how it's going to work. Plus, it kind of makes you look smarter. Thanks, Ryan. Only laugh I got. So it controls ventricular response rates in AFib, A-flutter, and multifocal atrial tachycardias. And it's used after adenosine to treat refractory reentry SVT in patients with narrow QRS complex and adequate blood pressure. So what are some of the, where's the main area that it's working on? The atrial stuff. All right, so it's going to work on the atrial arrhythmias really well. Your beta blockers, Sotalol. It's a non-selective beta-adrenergic blocking agent used to treat VTAC and SVT. Non-selective. So that means that it's going to work on what? Beta 1 and beta 2, right? Because remember, even going back to advanced EMT, beta 1 and the beta 2 receptors all have properties that may be a little different than the other. All right? Like your beta 2. What does beta 2 do? It causes bronchial what? All right? And vasoconstriction, right? So with this, it doesn't select beta 1, beta 2. It just works on the beta sites, all right? So it's blocking the effects of the sympathetic nervous system. I always thought that folks just took beta blockers to help with blood pressure, all right, because they vasodilate. But they also are very important in heart rate management. When I was working in the unit, we would have patients that their heart rate would shoot up. We'd go in and give them some labetalol, and you could see it right before your eyes, it just fluttering back down. But it's also type 3 antidysrhythmic that works on atrial dysrhythmias and life-threatening ventricular dysrhythmias. It's not commonly used for dysrhythmias on your algorithm. Amiodarone. Amiodarone is, so it's a class 3 antiarrhythmic agent. It treats SVTs and ventricular arrhythmias. So, amiodarone can kind of do the job that adenosine can't do. Adenosine can just work on SVTs, and that's it. But amiodarone can work on ventricular arrhythmias as well. The main times that we use it is going to be for VFib and VTAC, cardiac arrest. Alright, as our antidysrhythmic for VTAC, VFib arrest. Okay? Y'all following me? Y'all good? I know it's long. Alright. Within the VTAC, VFib pulseless arrest algorithm, and I'm kind of jumping ahead right here, but we'll come back to it. 300 initially, if no conversion, then 150, right? You remember that? If you convert with it, then you're going to want to do what?
Use that as your drill.
Start an infusion, right? Mag, we're going to use torsades and torsades, right? Polymorphic. Remember torsades, twisting at the point, so you see a little bit of VFib and VTAC and all that. And your dose is 1 to 2 grams. So with VTAC with a pulse, we may consider doing some of these medications here. Alright? Most often your frontline medications for VTAC with a pulse is going to be an amiodarone drip. Alright? An antidysrhythmic drip or a lidocaine drip. Alright? Epi is used in your pulseless arrest. It's known for its vasoconstrictive effects and its ability to increase cardiac output. Why does it have the ability to increase cardiac output? Because it speeds the heart up, right? But it also has some contractile effects as well. Epi is considered a vasopressor. It means it presses down on the vessels, constricts them. I just told you that it binds to the alpha-1 adrenergic receptors. If we have direct vasoconstriction, if we were vasodilated, that means that we had problems with what getting back to the heart? Blood at preload, right? So if we can vasoconstrict, we can increase that pressure, we're going to be able to perfuse better, right? Epinephrine also helps with the beta-1 adrenergic receptors, and it improves cardiac output by what I just told you, increasing heart rate, increasing heart muscle contractility, and increasing conductivity through the AV node. All right, so we're going to have a more fluid contraction. Okay? So what is your dose for epi? 1 milligram. 1 milligram. That's your cardiac dose. 1 milligram of a what type of solution?
1 in 10,000.
1 in 10,000. Alright? Now you may use epi again for your bradycardia. Remember your 3 drugs, atropine, dopamine, and epi. And we just talked about that. Your ET tube. The meds that we give in the ET tube. Have y'all talked about that? Okay. You need to double the dose. Naval. Narcan, atropine, vasopressin, epinephrine, and lidocaine. You might have heard lean.
Yeah, without the
Lean.
V.
Lidocaine, heavy atropine, and Narcan.
So we do vasopressin. Okay. It's just double the dose.
Double the dose. Why would we give medication down the ET tube?
You can't get vascular access.
Yeah, you can't get back vascular access, and so you do have pretty direct vascular access at the alveoli, right?
What was in?
Narcan. All right. Lidocaine was removed from the pulseless arrest diagram in 2010, but is considered a suitable alternative if amiodarone is ineffective, or if your service just doesn't carry amiodarone yet. Everybody's going to be required to carry it, but it has a very short shelf life and it's very expensive. All right. So in ACLS, your indications for lidocaine, ventricular arrhythmias. That's really where it's going to work, is on your ventricular arrhythmias. And basically lidocaine, for lack of a better description, it goes in and just numbs up all those ectopic firing ventricular myocytes. Alright? There's probably a lot deeper scientific explanation to that, but that's what I think. Alright? It can be used for stable monomorphic VTAC and for stable polymorphic VTAC, but it's going to be in a drip. So your lidocaine dosaging is 1 to 1.5 milligrams per kilogram. May give an additional 0.5 to 0.75 mg per kg IV. For perfusing arrhythmias, that's going to be VTAC with a pulse. If you got wide complex VTAC, your dosages range from what you see there. Usually you're going to go more along the lines of the 1 mg per kilogram. Got it? Now this is just a dosage clock. If you give lidocaine and it converts to lidocaine, then you're going to need to put them on a drip. So let's just say that it took 2 doses of, or 2 milligrams of lidocaine to get them to convert. We're going to go to the next one up, which is going to be 3 milligrams, which is going to be 45 drips per minute. All right. So it's very easy to remember. If we give 1 milligram, then we're going to the next one up, and we're going to 30. All right. And then here's what y'all been looking at this whole time, your tachycardic. Now, very important with all of your ACLS algorithms are going to be what? Your reversible causes, your H's and T's. All right? If you've got an underlying rhythm, an underlying bradyarrhythmia, tachyarrhythmia, or pulseless arrest, but it's because of one of the H's and T's, if we don't go back and reverse those causes, we're fighting a moot point, right? We've got to fix the problem that caused the arrest or the tachyarrhythmia or bradyarrhythmia in the first place. All right? Y'all still following me? Okay. So, when we manage a tachyarrhythmia, what's the first thing we're looking at? Stable or unstable? Hemodynamically stable or unstable? Then we're looking at where is it originating from? Is it wide complex or is it narrow complex? If it's wide complex, we're checking pulse. If it's a wide complex and we have no pulse, we're moving on to our VFib VTAC algorithm. All right, pulseless arrest algorithm. If it's wide complex with a pulse, what are we doing? We can try some adenosine. We can try vagal, usually not going to do a lot for the wide complex stuff. Try some adenosine, but then we're going to need to do an antidysrhythmic. All right. Now, if they're unstable, we're going to look at what? Cardioverters. All right. Narrow complex. We've identified it as a SVT of 180. They are unstable. What are we doing? Huh? They are unstable. We're cardioverting. Synchronized cardioversion. Remember, that's why on tachyarrhythmias it's so important to identify stable versus unstable. All right? Stable, we're synchronized. Unstable, we're synchronized cardioverting. If they're stable, it's a SVT. We're giving what, Hunter? How much? 6 milligrams. If that don't work, we're giving what? 12. All right? If it's refractory or if it doesn't work with adenosine, what other meds can we consider? All right, we can look at amiodarone. lidocaine, look at your beta blockers, which you won't have on the truck. Alright? Any questions? Y'all good on this? Good on tackies? Y'all need another break or y'all good? Huh? Alright, not moving. Cardiac arrest. So we did our too fast, too slow. Now we're at our not moving. Warnings of cardiac arrest: atherosclerosis, underlying cardiac disease, drowning, trauma, things like that. Of course, it's going to take on a whole different aspect if it's a traumatic arrest. Cardiac arrest management requires a systematic approach that is rehearsed. When I work on the truck, I don't mind cardiac arrest at all, because you really, honestly, don't have to think a lot about it. It's all right here. And it's not that many steps, right? Because number one, cardiac arrest, it don't matter what it is, we're doing what from the get-go? Then we're doing what? Defibrillation. Then we're doing what? CPR, starting IVs, giving medications, right? Then we're doing what? CPR. Then we're doing what? Advanced airway if we have time. Then we're doing what? Shocking. Then we're doing what? CPR, right? I mean, it's just an algorithm. You just follow the same thing every time, all right? So, just quickly through this review right here, BLS, instead of ABC, we do what? CAB. Because of your chain of survival, early access, early compressions, right? So we're doing circulation first. We're checking pulse first. The idea behind it is the fact that they're not breathing, but if we start breathing for them and their heart doesn't work, then all we're doing is just pushing oxygen into a stagnant vascular system, right? How often should you swap? 2 minutes. 2 minutes. You should swap. You should swap. Why should you swap?
You don't notice yourself breathing less.
Right.
Quality compression.
The tireder you get, the more ineffective your compressions are, right? So your single rescuer is 30 to 2. All right. Do not interrupt CPR compressions except for the things you see here, but you shouldn't have no more than a 10-minute delay, right? Y'all ever seen the diagrams where how...
10 seconds?
That's what I said.
No, you said 10 minutes.
10 seconds. 10 seconds, yeah. Have y'all seen the diagrams where how much perfusion's actually lost just in 10 seconds? And it actually takes, I don't remember the exact numbers, but it actually takes like half of your next compression cycle to even start getting perfusion back to the body. Alright? So, even if you don't do anything else, if you can just keep good compressions and defibrillation, you're doing the most good for that patient. Alright? I've worked tons of codes. You know, a lot of y'all may have worked tons of codes. But I've been in situations where compressions weren't the priority. The priority was let's get in our fancy IVs and getting our intubation and all that stuff, doing all of our ALS stuff, and we forget about the compressions, and what happened? It's not a good outcome, right? So the biggest differences with your BLS and your ACLS is your BLS, you use an AED, let the AED monitor for you, right? We're doing it now. We're using our own judgment. We're still minimally interrupting compressions, but we're still taking looks at the monitor. Can you get a quick look in the pads setting?
Mm-hmm.
We can look at our lethal dysrhythmias across the board in what lead? Lead 2. All right? And your pads can pick up lead 2. Bottom line, we need to get them to definitive therapy. We're going to get to the hypothermia therapy here in just a little bit. The universal algorithm. Universal. It's the same across the board. All right? You know what you need for every arrest, right? Except instead of doing it as an AMT approach, we're now going to take our medic approach and we're going to have our drug box and our monitor, right? If alone, do not take time to carry everything. If alone, all you can really do is just quality CPR. Because if you're by yourself, and I can't think of a situation where you would be, but if you are by yourself, you're riding on the back of the truck or something like that and somebody arrests, you will definitely have longer than a 10-second interruption in compressions if you're trying to get IV and stuff like that. All right. Check pulse, no pulse, start CPR. Look at your monitor, look if it's VTAC, VFib. All right. As soon as we get on scene, they're unresponsive. We're checking pulse. If there's no pulse, are we taking time to put the pads on, or are we jumping right on CPR? CPR. We're jumping right on CPR. All right. Then do your 2 rounds of CPR. As soon as you get the AED on, you can check and go ahead and shock. And then do your 2 minutes of CPR. Go into your algorithm. If nothing's there, no pulse, resume CPR. If still in cardiac arrest, check and see if it's VTAC, VFib, PEA, asystole. How are we going to tell if it's PEA? Yeah. Yeah. All right. So responsive 911 CPR. All the way down. Right? Right. On this page, your biphasic is 120 to 200. I said 200 earlier. Most of the time it just says go with manufacturer's suggested settings. Alright? Our monitors, they escalate. They go from 120 to 150 to 200. Okay? Then a monophasic is going to be 360. You're not actually going to try to get your advanced airway in until further on down the algorithm, because you've got way more important things to manage than putting in an ET tube in, all right? Because we can pretty much do just as effective ventilations with what? Just a BVM or a combi tube or something like that, all right? I'm not saying don't do your intubation. I'm just saying it should not be a priority. Bottom line, your priority in cardiac arrest is what? Perfusion, compressions, all right? So, VFib, VTAC, algorithm. Your first line drug. So your pharmacological treatment, your first line drug. Epi, how much?
1 milligram.
Of 1 to 10,000. Or vasopressin, right? For which doses? All right, your first or second. And what's its dosage? 40 units. All right. How often do we give epi? 3 to 5. Alright? What about vasopressin? If we give vasopressin,
Just one.
You can substitute it
You
for
just substitute.
yes, you can substitute it for the first or second, so you could give epi, then you could give 3 to 5 minutes later you could give vasopressin, but it's at least 20 minutes before you would jump back into an epi or something like that. That's what the algorithm and stuff says, or not the algorithm, but AHA says, but
Say that again?
I've seen it.
So if you give vasopressin, you gotta wait 20 minutes before you can give another epi or anything?
So you don't want to give it for the first dose, that'd be points.
Well, it wouldn't be because it has the same properties as epi, alright? But it's going to last longer.
So would you wanna do that first?
That doesn't make sense. What you're saying. You're saying once you give vasopressin,
Keep
that
giving
every
it.
35 minutes is rolled out, you gotta wait.
You gotta wait 20 minutes for you to
Yeah.
give another.
You're not supposed to give epi after you give vasopressin.
Not
Yeah,
for at
I
least
know
20 minutes, right?
Right.
That's good.
I didn't know that. See, I thought it was saying.
That's the way that I've always understood it, alright?
I thought you
Is it
replaced the
like-
first dose
Mm-mm.
with epi with vaso, and then you rocked on with epi right away on.
Unless they've changed it since the last time I did ACLS, no. It replaces your first or second dose. Once you give it, it lasts. Alright? I'll try to do a little more digging on that, but that's the way I've always interpreted it. Alright? So, after we've done all that, our second line. Drug. On your algorithm. It's going to be an antidysrhythmic. Amy.
Hey, it says right here that further doses of, they don't give a time, but it says right here, further doses of epinephrine should continue to be given as indicated in RFR protocol.
Alright. That may have changed then. I'm glad you looked it up. Amiodarone. Alright, what's your dosage of amiodarone? Your first is 300. Okay? And then you could use lidocaine. What was the dosage of it?
1 to 1.5.
Milligrams per kilogram. Alright. And again, that's just the pulseless arrest algorithm. If spontaneous circulation, also called ROSC, occurs, then we're going to do our ongoing assessment. If it was a couple things are going to go into it, and still want to wait. Let me just wait till the end of the lecture before we talk about the hypothermia. PEA is an organized rhythm, but it's not accompanied by detectable pulse. This is also known, used to be known, it's commonly known as PEA now, used to be known as electromechanical disassociation. Alright? Remember, for your heart to pump, you've got to have those two aspects. You've got to have the electrical and the mechanical working together, right? So, we've got the electrical aspect, but we don't have the mechanical. How are we going to confirm PEA? We're just going to check the pulse, right? If we've got a PEA and so the difference in a PEA arrest and a VTAC VFib arrest is that PEA is going to have some type of organization to it. Alright? Does that make sense?
The rhythm's gonna have some kind of.
Yeah, the rhythm's going to have some kind of organization. I mean, obviously you can tell a VFib from a mile away, and you can tell a VTAC from a mile away. But it may be a sinus Brady, or it may be a junctional, accelerated junctional, or it may be any type of strip. But if you don't have a pulse, then we're going to treat it as if it's an asystole, because basically it is, right? We could give drugs to work on the electrical system, But if there's that disassociation between the electrical system and the mechanical system, then it's not going to really pick up where it needs to be. All right, all the things you see here, it may pretty much everything's just going to be kind of quivering in the heart. Well, yeah, I mean, VFib would be everything quivering in the heart, but I'm saying, like, there may still be a little bit of movement in the heart and all that, but it's so weak that it can't be detected by a pulse or anything like that.
But you could not hear it either, correct?
Mm-hmm. No, you wouldn't
So
be able
if you heard even the slightest little bit of a heartbeat, you would still wouldn't get clear.
Well, you're going to, I mean, you're going to rely more on your carotid pulses and your femoral pulses than you would listen. If you listened,
Well, if you're not sure if you felt it or not. Like
well,
if you think you did, but you're not sure if you did or not.
well, if bottom line is, if you listen and you do hear a little bit, but if it's not strong enough to give you a pulse, then it's not going to be strong enough to perfuse the rest of the body. So it's right there at that point to where it's about to be in full rest. Does that make sense? So you're going to need to still work. But there's a lot of things that go into that too. All right. Without getting into a lot more of the other stuff, I mean, you got to look at, is this cardiac arrest being caused by medical cause, or is this cardiac arrest being caused by something else? All right. So you got to look at the overall scene. The same old stuff. Pulseless electrical activity and asystole arrest is going to be the same treatment. We're going to do CPR. We're going to give a vasopressin, epinephrine or vasopressin. Okay? CPR, epi. CPR, vasopressin. All right? We're not going to do any shocking. There's no other medications that we can get. All right? It's just going to be CPR and a vasopressin. Does that make sense? So that's your BLS algorithm with just one medication. Right? If you've got a systole and you're looking at terminating efforts, you've got to confirm a systole in what?
More than one lead.
More than one lead. All right. Now that it doesn't really matter about the leads looking at the same place and all that stuff. It can be just more than one lead. All right. Same thing. CPR, vasopressin drug, epi or vasopressin. All right. Epi is a vasopressor drug. All right. Continue to go through post-resuscitative care. This is what's important. Couple things that you need to look in that's going to give you the kind of the green light to go ahead and initiate the therapeutic hypothermic protocol. Number one, was it a witnessed arrest? All right. Number two, was it a witnessed VTAC VFib arrest? Was the initial rhythm VTAC VFib? Did we shock? All right. If the answer is yes to those, and we get return spontaneous circulation back, then we start cooling them off. All right. How are we going to tell that we have spontaneous circulation? We're going to check a pulse. We're going to look at perfusion. We're going to look and see if they're taking breaths on their own. All right. If it was a VFib or VTAC arrest, there's nothing that says that just because we've got ROSC back, they're not going to go back to that VTAC or VFib. So what do we need to consider? A medication to keep them from going back into VTAC or VFib. All right? An amiodarone drip or a lidocaine drip. All right? If you get spontaneous circulation back, the heart's going to be very weak. All right? So it may be in a bradycardia. it may still need some assistance. It may still need some transcutaneous pacing, or it may need atropine or something like that. You just treat it. You just move from whatever algorithm you're in. All right, but you're going to stay in the post-resuscitative care algorithm. All right, the whole time, as long as they've got some sort of pulse back, we're just going to manage we're in the return to spontaneous circulation algorithm, and then they go into a bradycardia. We're still going to take care of the bradycardia, but we're still going to follow the Ross protocol as well. Does that make sense? So the therapeutic hypothermia, the whole purpose behind that is to slow everything down, to slow metabolism down, and it's going to lessen the neurologic effects of the brain. Because remember, what does a successful say? Walking out neurologically intact. All right. Avoid tracheal suctioning in an intubated patient when you have return spontaneous circulation. Why do you think that is? Y'all may not know this.
Slow it, right?
Yeah, it does a vagal response. It stimulates the parasympathetic nervous system. So we don't really want to slow down an already weak heart, right? And consider elevating the patient's head. Where do we cool them? What do we use? So we're going to find our main artery points. We're going to go under the arms. We're going to go femoral arteries. We may go on the carotids. All right, and we're going to put ice packs. It's very important that you get that information. Was it a witness arrest? What was their initial rhythms? Stuff like that, because that's going to make a big determination as to whether they actually initiate the Dr. Cool protocol whenever you get to the hospital. All right? Just real quick on the post-cardiac arrest care, we talked about the induced hypothermia. Why do you think a dopamine or epi infusion, why do you think those are going to be important to this patient?
Because that's what it took to get the patient back, so you want to keep those drugs maintained in the system.
Okay, but maybe, well, not really, because epidopamine or norepi, they're not antidysrhythmic, so they're not the ones that converted it.
The heart already being in a weaker state, you want to give it something where they can help keep it pumping strong?
Mm-hmm. You gonna say same thing? Yeah. So you've got a weak heart. You're probably in cardiogenic shock. There's no doubt. You just were in cardiac arrest. You're in cardiogenic shock. We need something that's going to help increase the heart rate, but we're going to need something that's going to help increase the inotropic effects, the contractile effects of the heart as well. All right? We're going to need something that's going to vasopress, all right, that's going to bring the blood pressure up. So dopamine, epinephrine, they all have these effects. Dopamine is probably going to be the easiest one because you've already got it mixed up in your drug. Okay? And then when to stop CPR. So you've got the presumptive signs of death, right? The presumptive signs of death. In a medical arrest, your presumptive signs of death are going to be what? This is our last slide.
Is yours the last one?
Yeah.
Up here? You want to hear?
On my desk.
No.
I'll
Yes.
clear it all.
They're going on mine. They're going on yours. This is mine. My whole life. Not yours.
I'll take Steve's
When to stop and eat pizza?
We're almost done. Rigor mortis, lividity. All right, so trauma is going to be decapitation, hemodissection, exsanguination, things like that, right? Do what? Well, if it is a hypothermic patient, if it is, I know what he meant. If it's a hypothermic patient, you don't stop it until their core temperature is raised back up, right? As far as American Heart, you got an unknown downtime, and they do not have signs compatible with life. All right, avidity, all that stuff. No bystander CPR was provided. When does tissue death start occurring? Within 5 minutes. All right. Spontaneous circulation did not return after complete ALS care in the field. We went 15, 20 minutes. They already had a 3 or 4 minute downtime. The farther out from the arrest you are, the less likely you're going to have return to spontaneous circulation, and then no shocks were administered. So, just a couple of review questions. What's the difference between synchronized cardioversion and unsynchronized? Yep, synchronized hits on the R wave, unsynchronized does not take any discretion, it just hits. Alright? What is the recommended dosage of electricity for the initial unsynchronized shock?
The manufacturers
Yep,
provided.
200 is what we're going to go with. Alright? How do you determine if you should use electrical therapy or pharmacological therapy on a tachycardia patient?
They're stable or unstable.
Stable, unstable. But not just stable, unstable, hemodynamically stable or unstable. Alright? Which is going to be pretty much the same thing, but include that in. What is the primary medication used to treat bradycardias? Atropine. What's the dosage?
25 milligrams.
In bradycardia.
So max dose of 3.
Yep. What is the primary med for treatment of SVT? Adenosine, 6 milligrams, then 12 milligrams. What is the electrical therapy dosage for synchronized cardioversion? You're going to have to look at your sheet for that.
Like 1.
There's going to be 2 things that you have to look at that's going to determine your dosage. Wide or narrow? Is it wide or narrow? What's your dosage for narrow complex?
50 to 100 joules.
50 to 100 joules. What's your dosage for wide complex?
100 joules.
100 joules. All right?
It also depends if it's regular or irregular.
And then the steps for transcutaneous pacing, we'll come back to that because we're going to hit that again in the lab, okay? Are there any other questions?